Good afternoon, everybody. Today I'll be talking about the anatomy of the pelvis and fetal skull as required from an obstetrician's perspective. I'm Dr. K. SARITHA, Professor of Obstetrics and Gynecology at Mallareddy Medical College for Women. So, if you look at the pelvis, it is formed by the two innominate bones and the sacral bone. The joints are the sacroiliac joints and the pubic symphysis. Pubic symphysis is a fibrocartilaginous joint, and the sacroiliac joints are the synovial joints. And the pelvis, actually, it has a false pelvis and a true pelvis. Above the brim of the pelvis, the outline of which I talked just now, it is the false pelvis. And what lies below the inlet of the pelvis and the outlet is called as true pelvis, about which an obstetrician is concerned, about which an obstetrician should know. So if you look at the boundary of the inlet, anteriorly it starts from the symphysis pubis, the pubic crest, the pubic tubercle, the iliopectineal eminence, the iliopectineal line, the upper border of the ala of the sacrum, and the sacral promontory. This semicircular line is called as the linea terminalis, and the linea terminalis on both sides form the inlet of the pelvis. So this inlet of the pelvis has the dimensions. Yeah, this is the inlet of the pelvis, and the the brim is bounded anteriorly by the pubis, laterally by the iliopectineal lines, and posteriorly by the ala promontory of the sacrum. So at the brim, what are the dimensions which are important? At the brim, the dimensions, the antero-posterior diameters are 3 now. If anybody, the brim of the pelvis has 3 EP diameters of obstetrical influence. These are the true conjugate, the obstetric conjugate, and the anatomical. True conjugate or the anatomical conjugate, the obstetric conjugate, and the diagonal conjugate. True conjugate is, or the anatomical conjugate. This is, try to remember it is A, O, and D. Obstetrical conjugate is the narrowest. The true conjugate or the anatomical conjugate, it starts from the upper border of the symphysis pubis to the sacral promontory. Obstetric conjugate is from the most prominent part on the posterior surface of symphysis pubis to the sacral promontory. And diagonal conjugate is from the inferior border of symphysis pubis to the sacral promontory, A, O, and D. Among these, diagonal conjugate is the only measurable diameter at the brim, and this is around 11 centimeters, and 0.5 to 1 centimeter, if you minus it, you get the obstetric conjugate, which is around 10 centimeters, and the true conjugate is again around 10.5 centimeters. Now coming to this is the antero-posterior diameter. Coming to the oblique diameters, the left oblique and the right oblique diameter. The oblique diameters start from the sacroiliac joint on one side to the iliopectineal eminence of the other side, and these are named as the right or left depending on which side they belong to. Now coming to the transverse diameter, and these are around 11.5 to 12 centimeters. Now coming to the transverse diameter, you have the anatomical transverse and the obstetric transverse. Anatomical transverse is one wherein the antero-posterior diameter is exactly bisected in the middle, that is the anatomical transverse. And obstetric transverse is one wherein the widest part between both the linea terminalis is the obstetric transverse. Now coming to the next, the inclination of the pelvis. The inclination of the pelvis, and a woman is walking, the antero-superior iliac spines and the symphysis pubis, they lie in the same straight line. So there is a certain amount of inclination of the pelvis. This inclination of the pelvis is the angle which is formed between the plane of the inlet and the horizontal. This is around 55 degrees, and if you look at the angle, this is between the plane of the brim or the inlet and the horizontal. Above that lies the complementary angle to this is between the plane of the inlet and the last lumbar vertebra. which is around 135 degrees. This is 55 and that is 135 degrees. The importance of knowing the inclination of the pelvis is in high inclination pelvis, when there is sacralization of the last lumbar vertebra, the inclination tends to increase, and this is called as a high inclination. In pelvis with the high inclination, there is difficulty in engagement of the fetal head. That is why high inclination. Whereas in a low inclination, which is when there is sacral lumbarization of the first sacral vertebra, then it is a low inclination pelvis and it is not of obstetric significance. Now if you look at the axis of the pelvis, at the brim, the direction of the pelvis is downwards and backwards, whereas the axis in the mid cavity is downwards and it's only downwards, and at the outlet the axis is downwards and forwards. This indicates the otherwise this is also called as a curve of Caris. Curve of Caris is downwards and backwards, downwards and forwards, whereas the fetus does not take this path. It takes downwards and backwards till the ischial spines, and from there it is downwards and forwards. Now coming to the, so far we have talked about the brim of the pelvis. Now we will talk about the plane of the cavity of the pelvis. The cavity of the pelvis has a plane of greatest pelvic dimensions and a plane of least pelvic dimensions. The plane of greatest pelvic dimensions, the boundaries are anteriorly it is the midpoint of the symphysis pubis. On the sides is the greater sciatic notches, and posteriorly between S2 and S3. Here, if you look at the antero-posterior or the transverse diameter, the minimum is around 12.5. That is why we are not much bothered about the plane of least pelvic dimensions, because the fetal head, which has a well-flexed fetal head, which has a BPD, biparietal diameter, or an engaging diameter of 9.5 centimeters, it can be fit into any of the antero-posterior or the transverse diameter at the greatest pelvic dimensions. Whereas the plane of least pelvic dimensions is of importance because this is the narrowest part which the fetus has to negotiate during the delivery. This plane of least pelvic dimensions, anteriorly the boundary is the lower border of the symphysis pubis. On the sides is the ischial spines on either side, and posteriorly it is the fifth sacral vertebra, which is the which forms the boundary of the plane of least pelvic dimensions. Now coming to the dimensions of least, it is bounded, cavity is bounded by the brim, below by the plane of the outlet, posteriorly by the sacrum, and laterally by the sacrosciatic ligaments and the ischial bones, or anteriorly by the obturator foramina and the ascending rami of the ischium and the pubis. Then coming to the cavity, so far we have talked about the boundaries. Now coming to the measurements, the this is the antero-posterior diameter, AP diameter at the plane of least pelvic dimensions is around 11 centimeters, whereas the transverse diameter at the plane of least pelvic dimensions is only 10 centimeters. The transverse diameter at the plane of least pelvic dimensions is otherwise also the interspinous distance, which is around 10 centimeters. Whereas the antero-posterior diameter at plane of least pelvic dimensions is 11 centimeters. And that is the reason why the fetus undergoes an internal rotation at the level of the ischial spines, because the transverse diameter is less than the antero-posterior diameter. Now coming to the outlet. Outlet, you can describe it as two triangles. If you look from below, the outlet appears as two triangles with the common base, which is the intertuberous diameter. Between both the ischial tuberosities is the base which is common to both the anterior triangle of the rhomboid and the posterior triangle of the rhomboid. So anteriorly the apex is symphysis pubis and posteriorly the apex is formed by the coccyx. At the outlet, the plane, the important diameters are the transverse diameter of the outlet, or the line between both the ischial tuberosities. This is around 11 centimeters, and at the symphysis, the AP diameter of the outlet is from the inferior border of symphysis pubis to the coccyx, which is around 12 centimeters. So here another important diameter at the plane of least pelvic dimensions and the outlet is the posterior sagittal diameter. This is a part of the AP diameter which is lying posterior to the transverse diameter at the ischial spines. The plane is bounded by anteriorly by the pubic arch, laterally by the great sacrosciatic ligaments, and posteriorly by the tip of the coccyx or end of the sacrum. So, reminiscing the measurements again. At the brim, the antero-posterior diameter is 11.5 centimeters, the transverse is 13 centimeters, and at the cavity, the AP diameter is around 12 centimeters. Interspinous is 10 to 10.5 centimeters. Antero-posterior at the outlet is 12.5 centimeters, and transverse diameter is 11 centimeters. Types of pelvis, if you leave, no pure types are seen. Usually the female pelvis is described as the gynecoid pelvis, and the typical male pelvis is described as the android pelvis, and the transversely oval pelvis or the platypelloid pelvis, or antero-posteriorly oval or the anthropoid pelvis. These are the four parent types of pelvis, but no pelvis is a pure type. Anterior segment can be of one type of pelvis with the posterior segment of another type of pelvis. Now coming to the gynecoid or the female type of pelvis, this is typically supposed to be seen in a female, in the typical female. The brim is a transverse ellipse, almost like a circle, whereas an anthropoid also is an ellipse, but it is antero-posteriorly, it is elongated. Now coming to the gynecoid and the anthropoid, the sacral angle or the angle formed by the brim of the pelvis with the first sacral vertebra is approximately 100 degrees. The sacral line or the side walls are parallel. The sacrosciatic notch is shallow and wide in a gynecoid pelvis, whereas in an anthropoid pelvis also it is shallow. Ischial spines in both the pelvis are not prominent. The sacrum is broad, shallow and concave. From above downwards it is well curved. The side walls are parallel. The pubis symphysis is light. Subpubic angle is at least 85 degrees, and in an anthropoid pelvis it's more than 80 degrees. The intertuberous diameter or the transverse diameter at the outlet is very wide, whereas in the anthropoid it is a little bit narrower. Outlet diameter of AP is long, whereas this also is long. Now coming to the other two pelvis, which is android and the parapelloid. Android is otherwise called as a otherwise also seen in the male type of pelvis. The brim is roughly triangular. The transverse diameter near the sacrum is shortened, and the typical feature with an android pelvis is as you go lower and lower down into the cavity, there is narrowing or funneling of the pelvis. Whereas a platypelloid pelvis is a kidney-shaped pelvis. The available transverse and AP diameters coincide. Then coming to the android and pelvis, the sacral angle is 90 degrees or less. Sacral side walls are convergent in an android pelvis, whereas they are divergent in a platypelloid pelvis. Sacrosciatic notch is very narrow in an android pelvis. That is the reason why, and the ischial spines are prominent. This causes many of the cases of deep transverse arrest is seen because of the sacrosciatic, the ischial spines being very prominent. The sacrum is flattened and the sacrum is broad, short and concave in platypelloid pelvis. The side walls converge, whereas the side walls diverge. The pubis is heavy and deep, whereas it is very shallow. Subpubic angle is acute in an android pelvis, and the intertuberous diameter is very much decreased, whereas it is increased in a platypelloid pelvis. Now coming to the pelvic examination and pelvimetry assessment. This is very important from an optic point of view, and it is a skill which has to be learned by all the undergraduates. So when you look at the clinical pelvimetry, we try to know the measurement at the inlet, the mid pelvis and the outlet. At the inlet, the only measurable diameter by doing a vaginal examination is the diagonal conjugate or the anterior-posterior diameter of the pelvic inlet. So a diagonal conjugate is from the The lower end of the symphysis pubis to the sacral promontory is the diagonal conjugate. So here when you do a pervaginal examination, whenever you are doing, when do you do a pervaginal examination to assess the pelvis? It is at term for a woman in labor. Fetus is the best pelvimeter, and the pelvis is best assessed during labor or at 37 completed weeks, which is also called as term. So what at the inlet, you try to you ask the woman to empty the bladder, lie down, take the consent of the woman, wash your hands, glove yourself, use some xylocaine so that you do not hurt the woman while doing a vaginal examination. Clean the external genitalia with a swab, and with 2 fingers of your right hand you enter the first bone which you feel on the posterior surface of the pelvis is the sacral promontory. So you prompt that, which you can tip with the middle finger till the point at which the inferior border of the symphysis pubis touches your gloved forearm, is the diagonal conjugate. From that, if you can subtract 1.5 centimeters, you get the obstetric conjugate. Okay. The next one is you want to assess is the curvature of the sacrum. Then next you look at all these are for the assessment of the mid pelvis. So mid pelvis, normal coming to the inlet, the obstetric conjugate is 10 centimeters and the diagonal conjugate is around 11.5. So you minus from 11.5, you take out 1.5 centimeters, you know the diagonal conjugate. Now coming to the mid pelvis, you want to say, after looking at the curvature of the sacrum and the sacrosciatic notches and the pelvic side walls, you look at with your gloved finger, stretch your fingers on either side or at the mid cavity or the ischial spines. The ischial spines, you stretch your finger, the forefinger and your middle finger of your hand, and if you are not able to palpate both at the same time, that means it's more than 10 centimeters and it is adequate. And the ischial spines should not be prominent. The side walls should be parallel at the mid pelvis. Now coming to the outlet of the pelvis, what we want to look at is the subpubic angle. Subpubic angle is between both the ischiopubic rami, the angle which is formed, it should be more than 90 degrees, and the subpubic arch lies 1 centimeter below this, and you should be easily able to apply 2 fingers with the subpubic arch. Whereas the ischial, and as you are coming out, you 4 fingers, make it as the knuckles of your 4 fingers, make your hand into a fist, and the knuckles of your 4 fingers put it between the women's ischial tuberosities, that forms the transverse diameter of the outlet, which definitely should be more than 8 centimeters. That gives an assessment. So summarizing the features of the pelvic examination, the points which are to be noted are the sacral promontory, the curvature of the sacrum, the side walls, the sacrosciatic notches on either side, then the ischial spines, the interspinous diameter, the subpubic angle, the subpubic arch, and as you are coming out, you look for the transverse diameter of the outlet. All these you can summarize and note whether the pelvis is gynecoid or not. Now coming to the fetal skull. The fetal skull is formed by, if you have the face, the vault and the base. The bones that form the skull are the 2 frontal bones, 2 parietal bones, 2 temporal bones, wings of the sphenoid and the occipital bone. The bones of the face and the base are heavy and fused, but the bones of the vault are the 2 frontal bones, the parietal bones, 2 parietal and the occipital bone. Between both the frontal bones lies the frontal suture. Between both the parietal bones lies the sagittal suture, and between the parietal bone and the occiput, you will get it is the occipital suture. So when the bregma is a membranous structure which is present between the unfused bones of the fetal skull. This is rhomboid and it lies between that bregma, otherwise also called as anterior fontanelle. The boundaries from the bregma are the sagittal suture posteriorly, the frontal suture anteriorly, and between the parietal bone and the frontal bone is a coronal suture. So both the coronal sutures. So it is a rhomboid membranous tissue which is from which 4 sutures radiate. Okay. Brow is the part of the fetal skull which lies between the bregma and the root of the nose. The face lies between the root of the nose and the supraorbital ridges. Okay. Then the occiput is the bony prominence between the posterior fontanella. The posterior fontanella, how to identify the anterior fontanella and the posterior fontanella are, the anterior fontanella has 4 suture lines radiating from the 4 edges, whereas the posterior fontanella has 3 suture lines. That is, on either side is the parieto-occipital line, and it is, and anteriorly is the coronal, the sagittal suture and the parieto-occipital suture line. Okay, so this is how it is. The posterior fontanella is formed. Then vertex is a diamond-shaped area between the anterior and posterior fontanelles and the parietal eminences. The sutures of the, as we have already enumerated, frontal suture is between both the frontal bones, sagittal suture is between both the parietal bones, coronal is between the parietal and frontal, and the lambdoid is between the parietal and occipital. The temporal suture between the inferior margin of the parietal and the temporal bones. Anterior fontanella already told, diamond-shaped space between coronal and sagittal suture, and it occupies at 18 inches. Whereas posterior fontanella is triangle shaped between the sagittal and lambdoid sutures. Fetal skull diameters. The important diameters of the fetal skull which have to be known are the diameters of the longitudinal diameters and the transverse diameters. Among the longitudinal diameters, you have the suboccipitobregmatic diameter from the middle of the bregma to the undersurface of the occipital bone in the neck. That is the diameter of an engagement in a vertex presentation of a well-flexed head. When it is in the vertex presentation, you have the suboccipitobregmatic diameter. Whereas the suboccipitofrontal diameter is from the root of the nose to the undersurface of the occipital bone, and this suboccipitofrontal diameter is presented whenever there is a partial deflection of the head. The biparietal diameter is a transverse diameter which lies between the parietal eminence, and it is the greatest transverse diameter. So among the longitudinal diameters, we have enumerated the suboccipitobregmatic and the suboccipitofrontal diameter. Now the next diameter is the occipitofrontal diameter. Occipitofrontal diameter is from the root of the nose to the most prominent point of the occiput. A deflexed head, usually we see these cases occipitofrontal diameter is seen when the after coming head of the breech presentation comes, because it is not so well flexed. So that comes in this diameter, and with uterine action, of course, the flexion occurs. And then the other diameters which are important are the mentovertical to the most prominent part of the chin to the occiput. Mentovertical or occipitomental diameter around 13 centimeters, and this is the largest diameter seen in brow presentation, and no way 13 centimeters can deliver vaginally. So brow presentations usually go for cesarean section. Now coming to the submentobregmatic, it is easier to remember because here the bregma is common. So the submentobregmatic is from the chin to the middle of the bregma. So submentobregmatic and suboccipitobregmatic. Suboccipitobregmatic for a vertex presentation, whereas submentobregmatic is for a face presentation. Then why are the suture lines important? Why do we tell so much about the suture line? Because of the molding which occurs with the fetal head. For the fetal head to fit into the maternal pelvis, there will be certain overlap of the bones. So in all suture lines, you have two bones which can ride over each other. So frontal bones slip under the parietal bones. Parietal bones can override each other, and parietal bones can, at the posterior part of the fetal skull, it can slip under the occipital bone. So if they override each other, this molding of the fetal head is very important for the fetus to pass through the maternal true pelvis, because when molding occurs, we assess the molding. If the suture lines are just closer to each other but they are separate, it is given as grade 0. Grade 1 is when the suture lines meet. Grade 2 is when they overlap but they can be reduced by gentle digital pressure. Grade 3, the overlap is irreducible. In some of the books they give it as grade 0, grade 1 and grade 2 for irreducible overlap. So whenever there is an overlap which is irreducible, that means definitely there is a problem. There might be some amount of cephalopelvic disproportion.